I would like to, I'm grateful to Dr. R.P. Joshi, DDG TB, who has joined this meeting and accepted the invitation and joined the meeting. And as always, he makes it a point to be present in this meeting and support us and encourage us, and despite his busy schedule. And as we all know, I'd just like to say that this pediatric TB is a very challenging thing. As we all know, the samples are difficult to obtain in children, like sputum samples are difficult to obtain. So we have to go in for invasive samples like gastric aspirate, bowel. We are looking for new alternatives to get other samples which are non-invasive, like saliva samples or swabs taken, also stool samples. So these are the alternative samples which we are exploring, so to make it easy for us to diagnose pediatric TB. So as Dr. Neeta has said, also welcome the national expert for the session, Professor Meenu Singh. She is the CEO and AIIMS Rishikesh founding professor of pediatric pulmonology at PGI Chandigarh and AIIMS Rishikesh. And also welcome Dr. Ashok Bhardwaj, chairman of NTF. And thank you. And Dr. Neeta.
Thank you. Thank you, Dr. Manpreet. Sir, presence of DDG, Sir, Dr. R.P. Joshi is a great motivation factor for us. Sir has always been motivating us to expand the eco clinic for periphery. He is the guiding force for all of us who work in the field of tuberculosis. I request Sir to give his address to our attendees.
Namaste. Good afternoon, all. On behalf of Central TB Division, I firstly like to congratulate Director NITRD, Dr. Manpreet Bhalla Madam, and Mrs. Singla, Dr. Singla, and all the team which have started this new initiative of pediatric TB through the ECHO platform. NITRD has been a pioneer in adult difficult to treat TB clinics, and they are consistently running at very high quality over a period of nearly 3 years, which is really a remarkable achievement. And since last month, they have started the pediatric TB, which is another felt need of the TB program. So on behalf of Central TB Division, I again congratulate the faculty who are going to present the cases and all the experts. I see many known faces here. NTF Chair, Dr. Bharadwaj, Dr. Devan, and many others. So I thank all the seniors also to join. And special thanks to all the youngsters, because this is one field which is going to be more and more important. And tuberculosis is such a disease which is difficult to diagnose in any given patient, more so in pediatric population. And the way it presents, the way it manifests, the challenges of, like Dr. Bhalla was telling, challenge of collecting the sample. So it is very important that we all meet and learn from each other using this platform of difficult to treat pediatric echo clinic. So again, thank you for giving me this opportunity and wishing all the best to the program. Thank you.
Thank you very much, sir. Thank you for your opening remarks. Now coming to today's case. Today's case presentation is from AIIMS Rishikesh by Dr. Khushbu Kamal Taneja. She is a DM Fellow in Pediatric Pulmonology and Critical Care. The case expert will be Dr. Alok Yadav, who is a senior faculty CMO in Department of Pediatrics at NITRD. The national expert for the day is Professor Meenu Singh. She is Executive Director and CEO AIIMS Rishikesh. She is also the founding professor for pediatric pulmonology at PGI Chandigarh and AIIMS Rishikesh. So a very warm welcome to the team, and over to Dr. Khushbu for her presentation so that we can take the discussion.
Thanks so much, ma'am. Good afternoon, respected teachers.
Sorry to interrupt you, Dr. Khushbu. We would request everybody to take a pre-test before we start your presentation. So just 2 minutes for the pre-test. There are 6 questions. The link is there in your email that was sent to you. And So please take the pre-test also. So over to you, Dr. Khushbu, for presentation.
So, good afternoon, respected teachers. It's my pleasure here to be presenting a case from our team. This was a very interesting case that we have come across. I'd just like to confirm if I'm audible and my slides are visible. Ma'am, can I proceed?
We can see your presentation. Yes, Dr. Khushbu.
So, good afternoon, dignitaries, respected teachers, and all my fellow colleagues who are interested in difficult to treat tubercular cases. I'm very thankful to all our dignitaries and faculty who've given us the opportunity from our team to present this case today. Just coming to the specifics of the case. This is a 9-year-old female, Miss P. She's hailing from Murabba.
So your voice is not very clear to all of us.
Am I audible?
Yeah, you're audible, but I think you have to be a little away, or I don't know, away from the mic.
Better now, ma'am?
Yeah, it's better.
Yeah. So this is Miss P, a 9-year-old female hailing from Muradabad, Uttar Pradesh. She was admitted in our hospital on the 31st of May and she was discharged after a week. So coming to the history of presenting illness, she is actually a treated case of abdominal TB. She was treated 4 years ago. We'll be coming to the details a little later. And she had received treatment of pulmonary tuberculosis in September 2023. She presented to us with history of fever since the past 5 days and cough on and off since the past 1 year, which had been persistent. So this had been despite good compliance with the treatment as per the parents by history, and editing had actually been stopped by the doctors in March 2020. They told us that the cough was productive. She was currently expectorating around 3 to 4 tablespoons a day of mucoid whitish sputum, which had recently become even yellowish in color. It was non-blood-rich, non-pulsating. The amount had decreased while she was on ADT to just 1 to 2 teaspoons, but since the past 3 months, since her tubercular treatment had been stopped, there was increased production, which had worsened in the past 3 months. So, coming to her past history and just continuum of her spectrum. 4 years ago, she presented with pain abdomen, which was dull, aching, centrally placed, and diffuse, accompanied by fever, which was low grade going to high grade. She also had weight loss and appetite loss, for which she had shown to an OPD basis to a private practitioner. They had done a USG abdomen, which was suggestive of mesenteric lymphadenopathy. Her size of the lymph node was mentioned in the USG report as 2.5 by 1.8 centimeters, which was the largest lymph node. There were multiple heteroperitoneal lymph nodes and mesenteric lymph nodes. Mantle test at that time was done documented positive. So they had started the child clinically on TGT, which had been given for 9 months. There were just private OPD papers and no DOTS papers. She had good compliance as per the facts. After this, she again was asymptomatic till March of 2023 when she developed cough. It was initially dry, which became wet and productive later and gradually progressed. This was accompanied by fever, which was initially low grade to high grade, and there was weight loss and appetite loss, which peaked in September. In September, when she had worsening of symptoms, she was admitted at TMU Hospital in Uttar Pradesh in Muradabad, where she again they had done a sputum CVNAT, which was documented as negative, and she had thus been started 18 on clinical basis as pulmonary tuberculosis. They have an X-ray from that time, which was suggested. We'll be coming to that in the EKG. And now they had taken the treatment under DOTS, and there was good compliance, which has been confirmed by doctors. With treatment, her cough and her expectoration went down, her fevers went down, she started gaining weight, but which came to a stagnation. But again, in December of 2023, she developed pain abdomen with cough, which was much milder than before, but still present. And she had pain abdomen on her. So then she was admitted again in the same hospital where she was tested to have her LFT profile done, which came to be normal, and she was given IV antibiotics and one more X-ray was done. After this, her cough remained stagnant. She had decreased production of sputum, but it never went away and it was wet. Also, weight documented in November 23 is 20 kgs, while when she came to us, her current weight is 19.2 kgs. There was no weight gain in the past 6 months in this child. Also, by March 24, when her DOTS treatment was complete, when appetite was better, her habit was better, all the weight was stagnant, her ADT was stopped. But this time there was no culture or CVNAT which was found in the reports, all in the DOTS online, which was So since March to currently, she has had 2-3 bouts of fever on and off, which have caused her discomfort. They respond to medication. Also, the amount of sputum has increased, especially since the past 5 days when it has become yellowish in color. And other things that we asked for were that there was no history of dyspnea, hemopsis, icterus, headache, blurring of vision, or any seizures during or back pain during this worsening of symptoms. So she came to us on OPD basis in the last week of May, on which we had given her, considering that she had fevers, we gave her 1 week of antibiotic in the form of amoxicillin, and we sent sputum A, B, and C and checked X-ray and CT thoracic fingerprints. Coming to the past history, she had history of abdominal TB as we discussed before, 4 years ago, treatment taken by private means. In September 2023, she was diagnosed with pulmonary tuberculosis and there were no other significant past illnesses. Developmentally, she was appropriate for age and she had good scholastic performance before she fell ill. Immunization, she had received all vaccines as per NIS and she also had a BCG scar check on examination. Birth history was normal, birth clothes of vaccine were given. There was significant family and social history. She was born out of a non-consanguineous marriage to a low middle class family. When overcrowding was present in the Pakka house that they lived in, there were 6 members who lived in. There was a history of TB contact. So her grandfather had been diagnosed as pulmonary tuberculosis. There was cohabitation present. This was in 2015. At that time, no treatment had been taken. And further, in 2018, he had cough which had worsened, and he had one episode of seizure and altered sensorium. He was diagnosed, no documents available, but the parents told us as TB of the brain, that's meningitis expected, and he had expired after taking ADT for 3 months. But in those 3 months also, he had poor compliance. So no family members had been tested or any prophylaxis had been given to the other siblings or to this child. Also, socially, the father was an open man. This is a single family pedigree of a single generation. I'm sorry, they did not have details of the further generations. Grandfather had significant TB history and there were 3 siblings. All the other 2 siblings were doing well, 22 years and 18 years each. The mother said they were lean, but they did not have any cough or any fever during the same period. So coming to the clinical summary, this is a 9-year-old female child who was a treated case of abdominal TB 4 years ago, pulmonary TB 9 months ago. The history of TB contact was a suspected MDR TB contact as the contact had expired, with history of recurrence of fevers currently on and off and persistence of productive and no weight. Fever, although in the recent time, had responded partially to oral. So considering these clinical details, we had kept few possibilities. First being acute infectious causes. The first one being
In the question, just a moment, Khushbu, do we need to stop and ask the participants if they want to give any possibilities or what do they think would be the differential diagnosis in this patient?
Yes, ma'am, that would be a very good opportunity so that, if there are any questions regarding diagnosis till this point
Yes.
or about the history, we can take them now. Can I summarize it very shortly so that if somebody is joined late and if they've missed anything? Or Dr. Khushbu, can you summarize? Just
Yes,
when-
ma'am. This is a 9-year-old female child who had been diagnosed with abdominal tuberculosis clinically using a radiological and clinically by USG. Presenting lymphadenopathy was present 4 years ago, which she had received a private treatment of 9 months of ATP. With parents saying good compliance but no documentation. 9 months ago, again, she had presented with cough and fever and weight loss when she was diagnosed to have pulmonary tuberculosis. Again, received ADT of 6 months. He also had a family history significant after TB contact, who was her grandfather, who expired of TB-associated illness. So he was a suspected MDR case as per definition. But her current complaints of the presence of fever on and off since the past 3 months, worsening since 2 months, currently present in 5 days. And she had persistence of productive cough and no weight gain since the past 6 months. There was fever which was present on seeing an OPD basis, which had partially responded to oral.
So any questions about the history of this patient till this point? Any questions, we'll be happy to take them.
They can post their questions in the chat box or they can speak it out. It would be good if they put their videos on.
Yes, Dr. Khushbu, I must say, sorry, very well presented so far. All these details you have given. in September 23, when she was given ATT, was she microbiologically confirmed or not? Because in that slide, apparently it appears she was CB-net negative.
Yes, sir. So again, they had documented a CD9 negative, but they had seen the chest X-ray and they had also done a CT, based on which she was clinically and radiologically treated as sponge. There was no microbiological confirmation at that time.
And even at the end, in March 24, ATT was stopped and the culture was not done. But any smear or anything else was done to look for the microbiological status?
They had just said that the treatment was completed to the parents. Even on the DOS portal, they just updated as treatment completed and no sputum was done. Although there was production of her sputum had decreased, but it was still present. But the testing was not.
Thank you.
Thanks.
Hello. Yeah.
Hi, this is Dr. Wasim from GMC Baramulla. I had just one query whether in the history, did she have any history of diarrheas, recurrent diarrheas or constipations alternating with diarrheas?
No, sir, there was no
I
history of
think
any
this
other.
must have been in relation to her old abdominal tuberculosis. So there
Because
weren't any such complaints, Dr. Pushpa?
No, ma'am, no history of recurrent
There was-
diarrhea,
Okay.
alteration of bowel habits, just pain at that time, which was diffused.
there's one more thing that the history, there could be a possibility of cystic fibrosis, which usually presents like this. There's low weight gain in children and also they present with recurrent diarrhea. So that's why I was wondering whether she had any diarrhea.
So this child for cystic fibrosis to have thrived well for 8 years of her life is a little unlikely. Maybe a few mild variants, we could keep that as a possibility lower down. Although even birth history, meconium had been passed, there was no significant alteration of bowel habits then. For her to not have had any recurrent respiratory illnesses till 8 years and then suddenly just have TB and have worsening, maybe a little lower down. So please not very high.
Even the siblings you have mentioned, they did not have anything, any of the symptoms.
Yes, sir.
That may be another point which may not favor cystic fibrosis.
Yes. May I proceed now?
Yes.
Ma'am, if there are no more questions, should we move ahead?
Please go ahead. Yeah. And
Considering
be a
the
little
similar-
closer to the mic because you are a little and speak slowly and loudly.
Yes. Considering the same details, we had kept few possibilities ourselves. These included first acute infectious causes. The most likely possibility being the recurrence of tuberculosis. The points in favor for this would be fever and productive cough, and no vein gain and contact history positive. While points against was that there were good compliance to treatment in both the cases as per history. The second infectious possibility was acute bacterial infection. There was partial response to oral antibiotics, which was the point in favor. Points against would be again history of tuberculosis, weight gain not there, contact history positive.
Make her
Second poss-
he has to be closer to the mic.
audible now, so. Am I audible better, sir?
Voice is a bit muffled, so please be closer to the mic and speak loudly.
The second possibility is chronic suppurative lung disease, that is post tuberculosis. Points in favor, persistent productive cough with expectoration, which was increasing with fevers. There were fevers which were present on and off, and there was response partially to oral antibiotics. While points against would be that there was no hemopsis. Amount of sputum was less as compared to a child who would have chronic productive suppurative lung disease. Third possibility would be immunodeficiencies. The first most likely that one should rule out in all tuberculosis cases is HIV. Your risk factors are that she belonged to a low socioeconomic family, with the father being an auto driver, and this child had a longer than normal refractory course of her illness. While points against would be there would be no recurrent illnesses other than that, and she was not failing to thrive prior to her age of this acute illness. The second immunodeficiency more likely would be a maintenance susceptibility to mycobacterial disease, MSMD. Points in favor would be that she had a recurrence of TB and she had a longer refractory course, and it was multi-site involvement. It was just not one site which was again having a recurrence. But points against would be that siblings were fine and there was not any other associated illness in the parents, which would be a weak point against because it is the autosomal risk. Shall we proceed to examination, ma'am?
Yes, there's a comment in the chat box to rule out CVID. CVID is common variable immune deficiency. And actually, these children become symptomatic much earlier and they have recurrent respiratory infections. So the kind of course which this patient has had is that of having an abdominal tuberculosis and being diagnosed as that and then becoming normal later on afterwards. Then again getting pulmonary TB symptoms. So this is not what which happens in CVID. There the presentation is a bit different. So now we can proceed.
Coming to the physical examination, on general examination, the child was vitally stable. Her saturation on room air was 95%. She had mild tachypnea, respiratory rate of 30, a pulse rate of 100 beats per minute. BP was on the 5th centile, 92/56 in right upper arm in sitting position. There were signs of volume loss in the form of drooping of left shoulder, flattening of the left anterior chest wall. The head of the left-sided sternocleidomastoid muscle was more prominent. There was mild scoliosis, which was noted in the thoracic region, and the left scapular tip in the back was seen to be at a lower level with respect to the right. There was pallor present, atrial cyanosis were absent, clubbing grade 1 to 2, pan-digital upper limb were present. Lymph nodes are such non-palpable in the cervical region or the inguinal region or axillary region, and edema was absent. She had SMR stage of 2. Anthropometrically, all her growth parameters were between -2 to -3 centimeters of her weight. Her height was at -2 standard deviation, and her BMI was at less than -2 standard deviation. So she had chronic malnutrition. Coming to the physical findings, a few pictures were taken with the permission of the parents and the assent of the child. These show that the left sternocleidomastoid head is more prominent. There is drooping of the left-sided shoulder, and we can see that the internipple distance seems a little larger on the left side. And the lateral view, the left-sided anterior chest wall seems more flattened, as was seen even on inspection and palpation. On the back, we can see that the left-sided tip of the scapula is more prominent and it seems to be at a lower level than the right. On measurement also, we found that the interscapular distance, spino-scapular distance was less on this side as compared. Coming to systemic examination, on respiratory system, we first come to the inspection. The upper respiratory tract was normal with no other findings. Trachea was deviated to the left side and trail sign was positive. There was thoracic pattern of respiration. There was drooping of left shoulder. Left hemithorax was flattened, moving less compared to the right. And there was a clouding of lower lips on inspection. On the back, again, scoliosis was noticed and reduced spino-scapular distance was seen. There were no visible scars, sinuses, dilated veins, or any other accessory method seen to be used. Coming to palpation, inspected findings were confirmed. There was no tenderness on palpation in any intercostal space. When we measured the chest circumferences, we saw that there was a respiratory excursion of only 2 centimeters, which is the lower limit of normal, almost borderline. The right hemithorax had an excursion of 1.1, while the left hemithorax had a lower excursion of 0.8. And also the diameter of the left hemithorax was less compared to the right. Also, when we palpated the apex, it was seen in the 5th intercostal space itself, but lateral to the midclavicular line, suggestive of a mediastinal shift. On percussion, dullness was seen in the left-sided axilla, infraaxilla, interscapular in the lower zone, not in the upper zone, and the infrascapular region. On auscultation, just as a summary, there was decreased air entry on the left axillary, inter and infrascapular areas. We saw that left side had, as we discussed, decreased air entry in these areas, with vocal resonance being decreased in the simultaneous areas wherever air entry was decreased. Occasional wheezes were heard on the left side, and on the right side in the axillary region, there were crackles heard, as well as in the infrascapular region. So these findings were in summary suggestive of a left-sided volume loss, a collapse consolidation, with findings on the left side in the lower zone of consolidation. Coming to other systemic examination, in CVS, only the apex seemed to be shifted laterally, and other system examinations were cross. May we proceed now?
Yes, please. Any questions or comments from anyone? I think we should proceed with the.
Just the sequential X-rays of
So the clinical examination, have you added anything which would modify your diagnosis, primary diagnosis, which was after history?
Ma'am, it will go more in favor of chronicity now because we see that the left side volume loss signs are present. And one could see that there's some signs of mediastinal shift. So the acute differential that we had kept off, plus there was not as much fine crepes and coarse crepes with conductive sounds that would be expected bilaterally in a child who would have bronchiectasis or a CSND. So this is again going more in favor of collapse with some amount of consolidation.
So could this be a sequelae of tuberculosis rather than being another infection which has come up now after 9 months of treatment for permanent
Yes.
TB?
That is what it is looking like, at least on the left side. But there are a few signs of active change also in the form of steps being present and her expectoration being present. So there is still symptoms and signs of reactivation of disease also, which is still a possibility. But underlying
It hasn't gained any weight in the history also.
Yes.
And has continued to be less than third centile. Okay. Okay, should we proceed? Yeah. Let's see the chest X-rays.
Coming to her chest X-rays, this was the first X-ray which was done in September 23. Again, this is showing that there is consolidation in the left upper zone as well as in the lower zone, and there is mediastinal shift as can be seen. When we go to this X-ray in September, we see that there is more hyperinflation on the right side, which almost there's some amount of herniation of the right lung towards the left. There is a bronchial cutoff which can be seen at the level of left main bronchus with consolidation more concentrated towards the left lower zone. And there is some amount of crowding of ribs which progressively seem to worsen in the X-ray, which is seen in May. Again, in the X-ray in May, there is herniation of the right lung in the lower zone with consolidation in the upper zone as well as lower zone. CP angle cannot be commented on the second two X-rays because there is either mediastinal shift or there is still a possibility of some amount of pleural effusion, although our clinical findings are not stressed. Coming to the C.
Yeah. The right
CT
side parenchyma is normal.
There is some consolidated changes in the right-sided perihilar region. There's more prominence of the bronchovascular markings. And the December X-ray is showing speckled calcification. Not
Yes.
normal.
Please proceed.
Coming to her CT, so they had done an HRCT outside at TMU. Here we can see that in the spirogram, there is again the mediastinal shift that we had seen with herniation of the right lung. When we proceed to the lung window of the CT, we see that when we trace the trachea down to the carina, we see that there's division, and then the left main bronchus seems almost like a slit-like opening at just the distal to the branching itself, which is still showing some amount of aeration. So it is not completely blocked, but it is definitely being blocked partially, or it is being compressed. Similarly, in the lung, when we see the right upper lobe as well as the lingular segment are showing GGOs as well as centrilobular nodules in the left side with complete collapse consolidation of the left lower lobe and the epicosterior segment. When we go to the right side also, perihilar region, there is increased centrilobular nodules which are present. This is a continuation of the lung window. I'm sorry we did not get the film through the mediastinal window. So when we just trace the trachea down, we can see a bronchial cutoff. So there is some amount of aeration which is still happening to the distal part. And similar findings of almost a bronchiectatic sort of a caliber of the bronchus seen in the right-sided middle lobe, upper, and in the left side there is collapse as well as consolidation. Coming to the CT scan, which was done in May at our center. This is the Lycom video. Again, we will see that there is herniation of the right lung towards the left. There is hyperinflation compensatory of the right lung. The trachea is again seen being divided, and it is going into almost slit-like opening, but further showing some amount of aeration in a collapsed consolidated lung with destruction. There is cavitative sort of formation seen in the left side, and lingular is still aerated, but the lower lobe and base segments do not seem to be aerated there. Coming to the mediastinal window. With this contrast, we see that there is right paratracheal lymph node which is showing calcification and enlargement. Again, we see that there is caliber of the pulmonary artery as well as aorta is almost similar, but but there is subcanine lymph node, which is enlarged and calcified. And again, we see that there is chronic collapse consolidation because there is some amount of speckled calcification and more density of the vasculature in the left lower lobe segment. Lingular is still aerated, complete mediastinal sheath is seen with herniation of the right. Coming to the coronary window, we see that again the mediastinal seems shifted. The heart is almost going to the leftmost corner. We see that the trachea being traced down again is being deviated to the left, with the bronchus being cut off just distal to its opening, but some amount of aeration still being present. Chronic calcification of brain cells is seen. Similar findings are seen in these stills. So coming to the fact that we saw that these two CTs had findings showing almost chronic collapse consolidation of the left side with loss of volume, we kept the following possibilities and we planned a fiber optic bronchoscopy and bronchoalveolar lavage for this. We would screen as well as try to find out what was causing the blockage. So the first differential that we kept was endobronchial TB. The points in favor would be imaging was suggested because it seemed to be aerated just distally also. There was something that would be occupying the lumen from within. And clinically also we saw that there were signs of left lower lobe collapse. The second differential was extrinsic compression of the left main bronchus. So because imaging was also showing narrowing of the left main bronchus with distally expansion. But imaging did not show any lymph node, although lymph nodes were enlarged, but none was compressing the bronchus from extrinsic factors to cause almost a near collapse or complete obstruction. The third possibility was that pulmonary tuberculosis sequelae would be considered because there was narrowing of the left main bronchus imaging with prolonged duration of illness clinically and persistent productive cough. And although it was a less common diagnosis, so we kept it lower down. Thus, we planned for BAL, that is bronchoalveolar lavage, and the samples were planned to be sent for infective workup. That is AFP, CBNAT, MGIT, because culture had never been done, and we knew that this was a case which had a chronic history, and bacterial culture, fungal culture, and QH. Proceeding to, shall I proceed to bronchoscopy findings?
Dr. Murthy had given these possibilities, which you have said that BAL would be sent for fungus and for all kind of fungus, like including nocardia and atypical mycobacteria. So all those will be, the investigations will be done on BAL samples and whatever sputum she was producing. And we also do GL gastric lavage in these patients and send them for samples. So we can now go for bronchoscopy, the finding on bronchoscopy.
So this is a video. Once we had crossed over to the trachea, we saw that there was narrowing on the right side. There was grade 1 tracheomalacia, as can be seen in the dynamic compression, which is more on the one side. Although when we reached up to the lower end of the trachea, there was again narrowing. Secretions were seen trailing down the trachea. This is at the carina. Then we turn the scope to the left side. This is the opening of the left main bronchus where thick secretions were seen pooling through. We tried negotiating the scope 4.2 outer diameter, that is standard pediatric scope, into this opening, which would normally be easily traversed up to this number LC2, LC1 and further divisions in a child of this age. But here we were not able to negotiate. On doing further suctioning and secretion was taken for lavage, we were able to see two openings, one at LC2, but we were not able to negotiate up to the LC2 using the pediatric scope. One opening seems patent, but we were not able to clearly see because some amount of aeration and bubbling seen from the upper opening. But the lower opening, we were not able to comment. So we changed the scope to the ultra-thin scope, that is 3.0 outer diameter scope, which was now at least able to negotiate up to LC2. The lower opening seemed completely collapsed. Stenodes were being blocked by some mass we were not able to make out. But the upper opening seemed patent and there was air bubbling seen through it. This is the ultra-thin scope finding. We see that the upper opening seems patent. But lower, when we are going down, we can see there is something either obstructing it or it is fibrous and stenosis. We were not able to see. And then when we pull back to the carina, we were able to find that this is LC2 itself, beyond which we were not able to see. So the thick secretions that came up front were then taken for BAL. These seem to be draining out of the right left upper lobe, and sample was sent for infection. So after 6 hours again, we repeated the X-rays and we were able to see that the tracheal seems deviated. There's mediastinal shift visible, but the bronchus, which was cut off at a more proximal end, now seems to be aerated a little more distally as compared to the previous X-ray done pre-bronchoscopy. There is more aeration in the left-sided upper zone, which could indicate a lingular segment being further aerated because which was being partially blocked by secretions. There's still herniation in the right lung, but the mediastinal shift is static, although there's some more aeration in the left-sided gills. On lateral X-ray, we are able to see there's opacity on the left side posterior to the retrocardial shaft. And but the bronchus seems a little better rated after bronchus. Coming to other investigations, this is the first CBC which was done on OPD basis in which we saw counts which were normal and there was 55% neutrophilic dominance. Further, when she came back 1 week later with persistence of fever, CBC was repeated. Then we saw a count of 16,900 with 47% neutrophil. CRPH was positive 1.24. ESR was 23. There was a mild APTT which was borderline. Other investigations were predominantly normal. Further, after 3 days of antibiotics, counts are in the same tunes. So we had continued antibiotics for 7 days. Also, we saw that HIV, HBsAg, HCV was negative. Coming to her samples, a sputum CBNAT done on OPD basis showed MTB, which was detected, but RIF's resistance was indeterminate. Because it was indeterminate, we sent a repeat sputum sample, which now was suggestive of RIF sensitivity. While AFP was positive and the bronchoscopy had been done, while CBNAT was NTB detected with RIF sensitivity. Her sputum culture, which had been sent on OPD basis, by now had come, suggestive of Pseudomonas aerogelosa. Colony count was borderline at equal to 10 to the power 4 CFUs. But sensitivity was seen to ceftazidime, piperacillin, cefepime, leoflox. And her BAL culture was sterile. MGIT had been sent for BAL. Till now, it has been reported as smear suggestive of AFB positivity. But as 2 weeks are not over, we don't unfortunately have the interim report yet. Shall I proceed now?
Just, Dr. Khushbu, just one question, please. Looking
Yes.
at the X-ray, CT scan, and the bronchoscopic findings, don't you feel that the probability of post-TB sequelae with the bronchial stenosis is more than the endobronchial tuberculosis in this case?
Yes. So we had that possibility once the scopy was done, sir. But since she did have clinical symptoms, so in a patient where the CBNAT would have been positive and maybe an MDIT comes negative, still think of stopping treatment because this looks more like stenosis. So there is definite signs of post-TB lung disease with bronchial stenosis on the left side. But since she did have symptoms, she had fevers which were ongoing, her sputum was increasing consistency, there was no weight gain. So there was still scope of there being some reactivation because clinically she was matching. Which is why we sent the MGIT, because MGIT is still rate the gold standard. Even though sensitivity of this is also around 70-80%. But that till now we have an AFP which is positive. So for the smear to be positive, there have to be live fasciitis done. So which is why we are considering that she would have, and we've given her treatments.
You see, in that context, if there is endobronchial stenosis and there is a the post-stenotic there is consolidation or infection by the TB, even that can be CBNAT positive and smear positive. So my point was looking at the scopy findings, CT and X-ray. I think the probability of stenosis is higher than the endobronchial tuberculosis. They can coexist, that is okay. But looking at that, that was my feeling.
Yes, sir. That's exactly what we kept in our diagnosis because we did see that she had post-TB lung disease with partial stenosis of the left main bronchus and left lower bronchus, almost complete stenosis. With recurrence of PTB, we're thinking more along the lines of RIF sensitivity because CBNAT is positive. We have labeled it as recurrence because again, symptomatically she's present. MGIT smear is positive. Although once the MGIT report does come as an interim or even at 6 weeks, we can reconsider the labeling of this recurrence. But till now, in the benefit of NTB and NTBs being in 2024, when we have a target in 2025, I would prefer to treat and err on the higher side in this child because she has symptoms. Because clinically, she seems to be having failure to thrive, having cough which is productive, sir. Hence, we've started her on treatment as of now. But obviously, once we do get the MGIT report, the plan then changes. So in a previously,
Can the smear be positive? Could it be like dead bacilli or? I mean, we should see the morphology of the bacilli because they look a little different if they are dead bacilli. But in this case, the smear is positive and CB-NAT is positive. If the smear is positive, CB-NAT is going to be positive because that is going to detect the DNA. So I think the possibility of sequelae being present is definitely there. And another culture for Pseudomonas has also come positive in this patient. And so her current symptoms could also be explained on the basis of some pyogenic infection. But one cannot totally rule out tuberculosis in this kind of a setting in a child who is not thriving at all and has had 2 episodes of treated tuberculosis in the past. So one would have to think of MSMD or things which are predisposing to difficult to treat tuberculosis. So I think we have sent those investigations, but I
Yes.
don't think we've got yet interferon gamma or IL-12 or anything for MSMD.
Interferon gamma counts independence, they were not affording, so we were not able to send that. Although we have sent the MGIT, the interim report is also awaited. It is why we wanted to have this discussion with our learned experts as to when a child who has such a persistence of symptoms and such a persistence of CB-NAT positivity, the AFB smear is also coming positive. So one should err on which side is what we wanted to discuss today.
No, I think we usually treat them if they're symptomatic and if they be positive. I mean, if you go even by the guidelines, they would need to be.
So our final diagnosis was post-TB lung disease of left main bronchus partial stenosis, left lower bronchus stenosis with recurrence of tuberculosis, drift sensitive. In a previously treated case of abdominal and pulmonary tuberculosis, clinical and radiological diagnosis then never microbiologically confirmed, with chronic collapse consolidation of the left lower lobe with chronic malnutrition.
May I come
So-
in? May I come in just at this stage? You see, now as we discussed, ma'am also said that now we are at a stage we need to decide whether it's a recurrence of TB or this is post-TB sequelae with superadded pyogenic infections. And she has taken treatment twice, and the last treatment was completed in March itself of this year. And now again, she is on Scopy and BARD and sputum as well. She is positive by CBNet, and one smear is also positive. And you see in our practice, being a referral hospital here in NITRD, we keep on getting such cases. And the worst scenario is when they have been treated for the drug resistance TB for about 2 years with longer regimen, declared treatment completed or cured, and then within 5-6 months they come up again with some symptoms like fever, cough, maybe for short duration, and they have CBNet positive. So in these scenarios, it becomes really difficult to see whether this is recurrence of TB or a superadded infection, which could respond to this. So ideally speaking, as ma'am also said, the culture is the best answer. If culture is positive, we are dealing with live bacilli. And if you see the literature also, which I think you have also reviewed, that after the cure of the TB, there can be persistence of the TB-NAT in about positivity in about say 7% of cases, with a median of say they said in one of the study they said 11 months, ranging from 7 to 19 months. Although they are uncommon scenarios, but I think they've in this article of 2018 they even discussed the probability of having a true TB versus false positive CBNet versus true CBNet. So they found that in cases where it is a false positive CBNet, the bacillary load could be low, which could indicate that cyclic index is higher in these cases, which they found, compared to the cases which were not falsely positive. Also, they found that this sputum could be less viscous. The X-ray, like in this case, uh, I may say that there is no significant deterioration in the X-ray between the previous episode. So, plus even the clinical probability is not very high in terms of the short duration of symptoms and partial response to treatment. So, such are the cases where we are really cornered whether it is recurrence of TB or not. But as Naim also said, it is better in such cases who is failing to thrive and losing weight, low BMI, better to treat the child rather than not treat the child. and review the case again once the culture report is available. Because in a smear positive case, we expect culture to be positive if it is truly a recurrence of TB. So that's where we are, that we may start the and then follow up, especially with the culture and clinical.
Yes, sir. As you rightly pointed out, we have also started the patient on first line EPT again. This time with strict compliance to DOT, as with the last times we did not have proper documents for this scheme. So we have an 8P smear of the MGID being positive. The interim report is to come in a few days. The plan for further treatment is to be decided as per the final MGID culture. Until then, we plan to continue 8Ps. We plan a repeat bronchoscopy after 4 weeks because the Pseudomonas aeruginosa colony count was just at 10 to the power 4, which is just a borderline positive. So for her symptoms to be just explained by that looks unlikely. Plus, her fevers do not completely respond even to IV antibiotics. So we plan to, once secretions are cleared out with some amount of oral antibiotics, we plan to repeat the bronchoscopy and reassess the left bronchial architecture with secretions more clear, so with a smaller scope. Again, if there is a possibility of now there being more interventions being planned for such post-TB sequelae also. Once the acute phase of illness, either tubercular or bacterial, is taken care of, and the bronchial anatomy is more stable with less inflammation, a controlled radial expansion of balloon dilatation is a possibility which can be entertained in such a child if some amount of opening is seen in the left lower bronchus. If such attempts fail, one can also plan for a bronchotomy or a lobectomy. Especially if an MDR is proven. In an MDR, this will be a load of bacteria that needs to be removed as fast as possible to help actually improve the response to treatment. So in that case, upfront lobectomy could be planned. We also have sent an enforced upon getting the first line as well as second line LP done for this child. So she's had treatment completed and she could have resistance to any drug by now. We have instituted chest physiotherapy in central spirometry. And after the intensive phase of this EDT course is finished, we will also plan a baseline spirometry for her if she is also clinically doing well. Look for how badly her post-TB lung disease has affected her underlying lung pattern. May I proceed to discussion, sir? Ma'am?
Yeah, please carry on.
So coming to the common situation that we all face, where a CBNAT has come to be indeterminate. So this is a flowchart from the guidelines for EPTB, but it also applies to PTB, where if we see that CBNAT MTB is detected, but it is either sensitive, then we take it as sensitivity. If it is indeterminate, the ideal thing is to repeat the same sample. Unfortunately, there are some very precious samples like CSF or like BAL, which may not always be able to repeat. So if we have some of the extra sample line, we straight off send it to liquid culture. If we cannot repeat it anyways, then we look for some other site where the sample can be repeated and it is detected. But indeterminate is not equivalent to drift resistance. Also, we know that CBNAT has a high sensitivity of 95.7% and specificity of almost 99% when 3 consecutive samples are taken for detecting MTB in pulmonary samples, which is to say the GA, the sputum, induced sputum, or more sensitive in BAR. So when we get a case like this, where we have a persistently positive CBNAT done every time over here has come to be positive, what can be the cause? So we know that Gene Expert has a high sensitivity and a very good negative predictive value of 98% in all settings for low prevalence as well as high prevalence. India being a high prevalence country, it has a high sensitivity. The specificity is also 99%. So the fact that if MTB is detected, it does mean there is definite DNA, there is definite bacilli, dead, alive, the test cannot differentiate. So the false positivity can actually come from dead mycobacterial tuberculosis, as Sir had pointed out, that in a collapsed lung, there could be still some dead bacilli which would be harbored and not be cleared by secretions. So one has to be careful of interpreting these results in the light of clinical findings first and then be confirmed by culture. So if there is a alive bacillus, it would be grown on culture. Although there is one caveat of the culture contamination or inadequate sample. But when the adequacy of the sample is ensured, CBNAT is positive, there is alive bacilli, culture would be, and the child would be symptomatic. So there is again the question of how long can CBNAT remain positive in such patients. So in pediatric cases, there is a case report which has even documented CVNAT positivity up to 22 months, almost 2 years after the child was thriving well, treated well, but just as a case that had been done. So although the guidelines do recommend doing CVNAT at end of IV or at the end of treatment, we need to keep in mind the child before we test any test. In adults, they have documented positivity even up to 5 years or 7 years, as can be seen in this table, where there was one case in this case series which remained CVNAT positive 5 years after treatment, and the patient was actually doing well, ranging from anywhere between 5 months to 5 years. The patient, who is an adult in this case, needs to be taken into how the patient is doing to actually trust the report. Also, we see that, as Sir was telling us, they have done a study where they have seen in South Africa the CT value, that is how many, what is the CT count, almost a cutoff of 30 has been seen for taking a true positive of CVNAT. So the higher the CT counts, the low likelihood of the report being actually positive in a previously treated case. So the overall sensitivity in a previously treated case goes down compared to when it is taken for a naive case. So when there is a smear and culture positivity case, it is 97%, but it is a smear negative but culture positive case, CVNAT may just be positive for 37.5%. So it is a test, it is a very useful test, recommended by guidelines upfront, but one needs to keep a few caveats in mind in an atypical case. So coming to post-TB lung disease, now we know that this is an entity which has been upcoming, and 2019 was the first census. There's no guidelines, but there are recommendations which have been taken up, especially in adults. Pediatric data is still lacking, but there is no dearth of such sequelae to be seen. So it is results from a complex interplay between the host organism and the environment, and it actually affects the long-term respiratory health. So it can be an overlapping spectrum of disorders affecting the large as well as small airways. It can range from bronchiectasis to obstructive airway disease, or the lung parenchyma may even lead to restriction, pulmonary vasculature in the form of pulmonary arterial hypertension or pleura, where there can be fibrosis in pleura. And this can further be complicated by co-infection and hemoptysis, as could have been happening in our case. So this is a review from Lancet, which has recently been published, where they have seen that anywhere from 10 to 70%. This one gives a value of around 60 to 70%, but there are other case reports and systematic reviews which have said that there could be a tracheobronchial involvement of all cases of pulmonary tuberculosis to the tune of 10 to 70%. And all those which have a tracheobronchial TB, 90% will show some degree of tracheobronchial stenosis. So the fact that tracheobronchial stenosis is not very commonly detected is because probably endobronchial involvement is not checked for in all cases. Where it is needed and the child is remaining symptomatic, one has to keep this complication in mind. So then we come to newer advances in the form of scope of intervention pulmonology. So it does not end with just giving ATT or just seeing that the X-rays improve or symptoms have improved. If a child like this comes to you and you see that there is persistence of a shadow on the X-ray, there's collapse, you're seeing chronic changes, one must consider these entities. Although not so commonly encountered, but when the one child that you might see it, it can make a difference to that child's life. By actually referring the child to a center which can deal with such a problem. So diagnosis of tracheobronchial stenosis mostly is done by bronchoscopy. And if trained radiologists who've seen CT chest of such patients day in, day out could have a high degree of suspicion, can also be picked up on radiology. Now, what intervention options do we have? One can consider controlled radial expansion balloon dilatation if it is still amenable, or sequential rigid dilatations to a more stiff fibrotic change, or even stenting in a patient where there is extensive compression or there is a chronic change, or in sequence to the dilatations. So in the same case series from Paediatric Pathology article, we see that there are 4 patients which were seen, which CTs which are almost similar to ours. The first they had done because it was a chronic collapse with on bronchoscopy, they found complete stenosis. They had gone for a surgery, while 2 of the center cases were actually treated with controlled radial dilatation. And the third one was tried with controlled radial dilatation, but then had gone to stent. So again, there is one more article, lots of literature coming from Southeast Asia for the role of ballooning in such patients. So here they had 29 patients, of which some adolescents were also included, with 55% showing a successful outcome after just balloon dilatation. So it is a relatively harmless intervention, although there is a chance of excessive pressure being given and pneumothorax. But considering a child who's 9 years like this girl, who has the rest of her life to her, just giving a chance with an intervention where she might have improved lung function and improved quality of life. So factors which they found to affect The outcome was that there was higher pre-ballooning FE1 and higher post-ballooning FE. So then comes the role of spirometry. It is not that a patient wants tuberculosis can never be tested for spirometry. The child remains infectious only while the IV treatment is ongoing, and then easily once lung functions can be done. And then it was the absence of left upper issues. So coming to adults, where they have gone one step further and they've actually found out a restenosis score. They have seen multiple factors which have determined outcome, including the lumen diameter, pre-intervention, spirometry tests in the form of multiple parameters, and symptoms in the form of dyspnea and the amount of cough. And they have used the lumen diameter, the spirometry FE1, and the dyspnea grade to actually come up with a score to whether such a child would be helped by intervention. So such is the forthcoming literature in adults. While in pediatrics, we need to be doing a lot more work, and such children need to be looked at with a high degree of suspicion to actually pick them up. So our take-home messages would be that every CDNAT positive does not mean that there is active disease. Even if once labeled our child like we have of starting ADT, our decision needs to be revised. It doesn't have to be labeled and stamped. Once we do get the MGID report, we plan to revise our decision if needed to actually continue treatment or not. And thus we need to keep our decisions dynamic in the clinic. When a CDNAT gives an indeterminate test for sensitivity, we must repeat the test. Indeterminate does not mean resistant. Also, interventions are now a need of the hour. They should be tried to avoid pneumotomy or lobectomy, which is a very major surgery with lifelong complications, and it has also seemed to improve quality of life compared to surgical interventions. And it is worthwhile in an attempt, but those cases need to be selected with the help of tertiary centers, which are doing such cases regularly, and they need to be an ideal candidate, which will definitely be helped by such a case. And there's much more today for the care of pediatric tuberculosis than just giving anti-tubercular medication. We can help the child, especially in rehabilitation and further living with those lungs for the rest of their life. Thank you. Okay, ma'am.
Thank you, Dr. Khushbu. That was an excellent presentation. Yes. So, ma'am, over to you for your comments.
Actually, I thought that there was a power failure at NITRD, so I just started talking. But I think Khushbu has presented various facets of a patient of tuberculosis, where she has had recurrent tuberculosis, but we should not let go the possibility of MSMD, which should be ruled out. And as far as interventions in pulmonary tuberculosis and post-pulmonary tuberculosis sequelae are concerned, I mean, this is a field which is emerging, and since we get so much tuberculosis, and we know that bronchial stenosis and this type of complications are common, and we have several times seen patients developing bronchiectasis on the lung, which is affected with stenosis and has persistent collapse, and then the other lung also gets, affected because of the infection in the collapsed lung. So I think it's worthwhile that we consider doing bronchoscopies and interventions in these patients. But as was told that dilatations can have problems sometimes, so one has to do OCT before that just to see the size of the cartilage, and various kind of surgeries are also now coming into picture, where bronchial stenosis, if it is a short segment, it can be surgically treated also. So with those comments, there are some, okay, Shifa Khan is asking for a link for post-test questionnaire. So people can take up their post-test questionnaire, but if there are any questions, we'll be very happy to take. And this problem of CBNAT coming repeatedly positive is not very uncommon. And I think this is something which we should be very careful in interpreting, because sometimes if CBNAT is just coming positive and the culture is negative and the smear is also negative, then one should look at clinical condition of the patient and only then go ahead. And there was a question in the chat box, Khushbu, about LPA in this patient. So was line probe assay done, and what's the report of that?
We have sent the line from SNR with the BAL sample, because that was showing the smear also being positive. Although with the MGIT, once the culture is grown, then the secondary LPA will be sent. The OPD basis, every smear was negative, so that could not be sent back.
Okay. Okay, thank you. So we'll be looking for that report.
Do you have LPA facility in AIMS also?
Sir, LPA, we are just getting it. It has been approved and it's in the process of being acquired. Actually, we don't have it right now. The samples have to be sent to Goon Hospital for that.
Now, this case, regarding this case might have been discussed in AIMS Rishikesh also. What were their
Yes.
views on preventive medicine?
No, sir, this was admitted with us. She's admitted with in our unit, and we have been discussing it amongst ourselves. It has not been discussed with anybody else, not with the adult pulmonary tuberculosis patients, with the consultants. But we are open to suggestions if there's anything we would like to do that.
Fine. Wonderful case, wonderful case. So I like the last line of Kushbu. Beside chemotherapy, we should go in for psychosocial support to the patient.
Yes, sir.
It's very, very important for her improvement. So
Yes,
it's
sir.
not the ADD which will bring her to life, but it is the psychosocial support which will boost her up. I am for it.
Yes, sir. So there's been a power failure in NITRD, and I got a message from Shifa Khan that we should announce that the next session will be on 16th of July. And Professor Bhardwaj, if you would like to make any more comments on this case and other.
I just thank the team's AIMS for bringing out an important case, and it is just we heard many things, so that is why this difficult to treat national clinic is there. So we find in a peculiar case, and it is being discussed at the national level. So I am happy that more than 150 people joined today. So I also circulated to the whole of people in medical colleges. So hopefully in future also we will have more audience and we will have more important cases which are to be discussed at the national level, peculiar cases. So thank you very much. Thank you all. Thank you AIMS team for bringing out an important case for discussion at the national level. So thank you very much.
Thank you, sir. There were a couple of questions which come up now. Can stool sample be tested for CVNAT? Be taken for diagnosis of TB amongst children? There are some studies which are going on a stool being tested for mycobacterial DNA. So, but they are not yet standardized. The second one, when spirometry can be done in TB patients, if they're smear negative, I mean, if they are non-infectious, when they're declared non-infectious, then spirometry can definitely be done in these patients.
Yeah, so ma'am, Dr. Mingu ma'am, I'm Dr. Manpreet. So I just wanted to comment on the stool for CVNet. So we also have already done a study for stool CVNet and compared it with using the RIF Ultra cartridges, and we compared it with the culture and LPA. So we have not published the results yet, but they are showing quite promising results. So we got the same type of results with the CVNet as end culture. So I think it can be a promising tool.
Yes, ma'am. Thank you. Thank you so much for giving us this information. So with that, I think we can wind up now. We thank you all the participants who have joined today. And thank you, Dr. Khushbu, for making a wonderful presentation. And experts, all the experts who are present for giving such wonderful suggestions. Thank you very much. So I'd like to log off after this.
Yeah, thank you everyone on behalf of NITRD.
Thank you.
Thank you, Dr. Bhardwaj.
Dr. Minu, may I close this session?
The ma'am is down low. Please feel like to see. Thank you so much, everybody. Martin. That's it. Thank you.
Thank you.